good morning, everyone. Over the next 30 minutes or so, we'll cover the basics of GIST. This is a basic lecture where I'll spend a fair amount of time on pathology and a little bit on the treatment as well. So these are the three aspects that I'll try and cover. So the revolution in GIST started in 2002 when imatinib was approved in GIST based on responses in a single patient, and this was published in the NEJM. And then uh, the use of GIST imatinib was allowed in adjuvant setting in 2008 and 2012. So GIST is an uncommon malignancy with a median age of in the seventh decade. It is rarely hereditary and it's associated with neurofibroma, Carney's, and a familial GIST syndrome. The commonest sites across the world are in the stomach. And besides the stomach, it's also seen to some extent in the small intestine, rectum, and esophagus. And the commonest sites of metastases are the liver and peritoneum. Now, classical textbook teaching says that they can be asymptomatic and we have incidental pickups. The majority of patients we see are predominantly symptomatic, and the symptoms are related to the location of the tumor. So if it's in the gastric region, you could have early satiety, vomiting, GI hemorrhages. These are very fragile tumors. So, even a little movement in large tumors can precipitate hemorrhages. If it's in the rectum, you could have incomplete evacuation and pain. So again, textbook teaching says that you find a lot of tumors which are less than 2 centimeters. In almost every region, if you find an asymptomatic nodule of 2 centimeters, it can be considered for observation. The reason why I have written EUS is because these lesions are commonly found in the duodenum and stomach, and these lesions can be safely followed up. Any lesion more than 2 centimeters needs to be evaluated and removed. So in case you have a nodule only with no other features more than 2 centimeters, you will remove it endoscopically. In case it's a larger mass, you will do a biopsy. The basic investigations we do in GIST is an endoscopy in case it's a gastric GIST, a CT, and a PET-CT. I've also mentioned EUS, and again, this is textbook teaching that since they might be small incidental pickups, for those who have been in the GI posting, you will realize that we seldom do an EUS because most of our patients are already symptomatic, and an EUS does not help us more than a endoscopy. Now, a CT and a PET-CT are good investigations for a GIST. I've just shown this picture to allow residents to imagine a bit. The classical growth in GIST generally does not breach the mucosa, and this is best seen or felt when you do a per rectal examination in a rectal tumor where you can feel a growth, but you will not feel any variance in the mucosa because these are essentially submucosal growths. And this in smaller growths, and EUS will tell you which layers of the tumor are involved. Another thing that a lot of you who have read up a little on GIST would read about is the Choi criteria. Now, the Choi criteria is a combination of reduction in tumor density as well as size. The thing that I want you to remember is even though the Choi criteria predicts very well between those who respond to treatment and those who do not, it has not been used in a single clinical trial till date. So while it is good to know that tumor density and size, and for PET it is a decrease in SUV less than 70% from baseline, it is not commonly used in terms of reporting as well as in clinical trials, but it's good to know. The standard size of these tumors is around 6 centimeters, and they are fragile tumors and they're surrounded by a pseudocapsule. So when the surgeons actually go in, they can find a nice plane between the tumor and surrounding structures. Even though on a CT scan, it looks like it is infiltrating, they are able to get the tumor out very nicely. Microscopically, there are three common types: the epithelioid, the spindle-shaped, and the pleomorphic. These have had some prognostic relevance previously, currently not so much. Now, from a diagnostic point of view on pathology, the key is a c-kit on IHC. Now, 90 to 95% of all GIST are c-kit positive. Now, c-kit, as you know, is not only seen in GIST, it is also seen in a host of other tumors that I mentioned here, like melanoma, Ewing's, and seminomas. Um, Generally, considering the locations you got GIST in, there should not be much confusion. But yes, the occasional melanoma in the stomach can present like this. Now, when I said that c-kit is key, around 5 to 10% of GIST patients are c-kit negative. What do you do then? Then you look at DOG1 or DOG1, which the full form is detected on GIST. This is a calcium chloride channel, and it is present in almost 97 to 98% of all GIST. So a combination of c-kit and DOG1 means that 97 to 98% sensitivity is there for the histological diagnosis of a GIST. And there are none of the other tumors which are c-kit positive actually will express a DOG1 as well. So the understanding point here being that if your tumor is c-kit negative and DOG1 negative, you would be hard pressed to make a diagnosis of GIST. Some of the other common markers that are seen are CD34, S100, and Desmin. This is purely of academic interest only. Now, for those who have been in the GI-OPD, we stress a lot on sending a c-kit mutation as well. So the c-kit is the receptor, the IHC, and c-kit mutation is what we also test. Now, what is the c-kit mutation and what are we looking at? Now, there are two diagrams here. One of them represents the KIT receptor and one the PDGFRA. Now, this is central to the pathogenesis of GIST. The driver mutations in GIST are c-kit or PDGFRA predominantly. Now, when we say that, there are three components of this c-kit receptor. One is around the membrane, which is called a juxtamembranal component. One is the actual receptor, and one is the kinases forward. Now, the commonest mutation in the c-kit itself is an exon 11, as I've shown here. Other mutations are in exon 9. So the primary commonest mutations in c-kit are exon 11 and exon 9. Exon 13, 14, 17, and 18, I've not shown 14 and 18 here, are common secondary mutations that develop once you are treated with imatinib. Now, in the 25% of patients who are not c-kit mutation positive, they have mutations in PDGFRA, and the commonest are the 14, 12, and 18 exons. Now, older methods of testing by Sanger sequencing used to say that 85% of patients will have a mutation of c-kit and PDGFRA. That means 10 to 15% of patients are wild type, that is c-kit negative and PDGFRA. However, now we know that if you do deep sequencing and NGS, actually truly wild type is only 1 to 2%. You have mutations which are now seen in succinic dehydrogenase, BRAF, RAS, PIK3CA, NF1. So these other mutations make up around 10 to 12% of all the drivers in GIST. And the SDH mutation is commonly seen in the younger pediatric age group. So truly wild type GIST is only 1 to 2%. Now, what is the relevance of this, besides identifying them? Just as a snapshot, this is what I want you to remember. If you have a c-kit exon 11, this is your garden variety of GIST. You will treat them with imatinib 400 mg. If it is c-kit exon 9, you double the dose, and this is shown to be of benefit. 13 and 17 are secondary mutations, as I mentioned earlier. They have some relevance in second-line treatment. The PDGFRA exon 18 is a D842V specifically, is resistant to imatinib, and the NTRK fusions now have newer drugs like larotrectinib in for use. Although NTRK fusions as a driver in GIST are rare. The other important thing that need to know from a pathological standpoint is risk stratification. There are around 10 risk stratification classifications, and I mentioned some of them here. The one that I find most useful and you can consider remembering is that you have 4 criteria to determine risk: tumor size, the presence of mitosis, primary tumor site, and tumor rupture. Important to note that these are all pathological characteristics, and the c-KIT mutation status has not been included in any stratification yet, though it is important. So the rule of numbers, rule of 5 is how I remember it, that if it's more than 5, it is generally high risk. More than 5 mitosis, again high risk. This is not all inclusive, but 5 is what you would like to remember. Coming to the management point of view, this is just an overview of, a flow chart of how to approach a patient with GIST. Now, at the left-hand corner, you have patients who have a resectable GIST. So for them, surgery is the key, and based on the risk stratification in the resected specimen, you would either consider for observation or adjuvant imatinib. Over the last 6 to 8 years, there has been a concept of neoadjuvant imatinib. Now, this is essentially used in G-junction tumors where surgeries are a little complex, so surgeons prefer their tumors smaller. In rectal tumors where there is some doubt on whether a sphincter can be preserved, you can have good downstaging with imatinib. So these are the 2 common areas where you will consider a neoadjuvant strategy. If it is an advanced disease with distant metastasis, you generally start with imatinib, except in the 2 scenarios that I have mentioned here, where in exon 9 mutants and D842V, you got to think about them. Now, there is some data even in advanced tumors with limited metastasis where you can operate the primary and distant mets. These are rare occasions in case of very good responses to your TKIs, but that is not the norm, and usually these patients are on lifelong TKIs. Just a few points about surgery that are a little different compared to resection of other tumors. One, they are generally easily resectable because they have good planes with nearby organs, but they are fragile and need careful intraop handling. Usually, lymphadenectomy is not required unless intraoperatively you find enlarged lymph nodes. Another thing that we are taught in solid tumors is the importance of margins. However, in GIST is one of those tumors where an R0 or R1 likely show the same outcomes. By that, I don't mean that the aim should be an R1 resection, but you will not redo margins or consider radiation, unlike other tumors where you would think of that. R0 and R1 resections have good outcomes or similar outcomes. R2 resections, where you have gross residual disease, of course, is a different story. And you should have 2 centimeters of gross margins by the tumor. Now, assuming that you have a resectable GIST, post-resection, the rule of thumb says that 50% of them will have a metastasis despite an R0 or R1 resection. And before the advent of imatinib, a majority of these patients, at least 50% of them, would recur in a couple of years. So, what are the factors that we will look at when prognosticating these patients? It is the risk stratification criteria that I had mentioned earlier. I've just written that here again, and the additional mutational status, which I was talking about. Now, imatinib is the baseline for management drug for almost all patients with GIST. And as we know, it occupies the ATP binding pocket of the c-KIT kinase domain, and thereby preventing phosphorylation and signaling. And this is basically the c-KIT mutation and the PDGFRA mutation, and the inhibition and by imatinib is the key to understanding how we treat GIST. Now, in patients who have resected tumors, what should we do? Post-resection, we should re-stratify them. And this was the first study which showed that adjuvant imatinib helps. So here they used tumors which were more than 3 centimeters and gave them either imatinib for 1 year or placebo. They also used 800 and 400, but for the purposes of this presentation, that's not very important. And they showed that you had a 15% improvement in recurrence-free survival, though the overall survivals were similar because crossover to imatinib was allowed. Now, in the OPDs, what you would see is that we routinely consider for 3 years of imatinib, and that is based on this AIO study that was conducted in multiple centers in Europe. It was a very large study conducted over 5 years with 400 patients. Now, as you can see here, the criteria that they used for classification of high risk is a tumor which is more than 10 centimeters, mitotic count of more than 5, and rupture. And the primary endpoint was recurrence-free survival. And again, in this study, if you look at the graph on your left, they showed almost a 20% improvement in recurrence-free survival, from 47 to 65% when you give 3 years of imatinib. This also translated into overall survival of approximately 10 to 11%, with median follow-up of almost 4.5 years. So this is the basis of using imatinib in patients in the adjuvant setting. Is there any data for using more than 3 years? There's a single phase 2 study which looked at whether this is feasible. This was published in JAMA 2 years back, and it was done in 91 patients, and you had given imatinib for 5 years, and the RFS was 90% at 5 years. So the key takeaways from this study is that patients were actually compliant with imatinib for a median of 55 months. That means that at least in trials, compliance rates are good. A majority of the recurrences occur within 2 years of cessation. But this is not the standard of care. This is only a feasibility phase 2 study. So even now, the current standard is 3 years. As I said, neoadjuvant therapy, the things to remember are that you generally consider neoadjuvant imatinib for anywhere between 4 to 12 months. And generally at 6 to 12 months, you would consider, you would attempt resection of the primary, and the indications I had briefly discussed earlier. The standard treatment for advanced disease is imatinib 400 milligram per day. There are multiple phase 2 and phase 3 trials. And the only difference is that you always start with 400 milligram, but in exon 9 mutants, you give 800 milligrams per day. This has been seen in multiple studies on post-hoc analysis. There is no single randomized trial in exon 9 patients where they have given 400 and 800 and said 800 is better. But it has been clearly seen that in exon 9 mutants, 800 is better. So, that is something to be kept in mind, which is why we stress on the requirement for a mutational status. And treatment should be continued indefinitely. And why is that? This is some of the large studies with imatinib. All the residents should read the EORTC and SWOG trials. What you should remember is that the older studies have shown that when you give first-line imatinib, the median progression-free survival is around 2 years, 18 to 24 months. The newer data sets show that imatinib improves the PFS to around 2 to 2.5 years. Now, this is likely because, more tumors are picked up at an earlier stage, smaller tumors, as well as it is now well known that the first line is a TKI. Previously, GIST used to be treated with chemotherapy, radiotherapy, and a fair amount of time used to go in those treatments. So, somewhere between 2 to 2.5 years is what you would expect your patient with GIST to do well with on imatinib. The response rates for exon 11 mutants are much better than exon 9 mutants because, as I said, the exon 9 mutants need a higher dose. Now, I had earlier mentioned that you should continue treatment in GIST without cessation, and there is prospective data for this. This is a French study where they stopped treatment at 1 year, 3 year, and 5 years, as opposed to continuing treatment uninterrupted. Very clearly, if you stop treatment at 1 year, 80% of your patients relapse within the next year. If you stop at 3 years, around 70% relapse. And if you stop at 5 years, still around 50% relapse. And, so there is almost a rapid regrowth within 1 year of stopping imatinib. And so the current recommendation is for continuation of imatinib till progression or tolerance issues. Another question is, can we reintroduce a higher dose of imatinib when, a patient has progressed already on imatinib? And this was a small study, but this is one of the prospective studies we have. And they actually said that the difference in PFS was only 1 month. Now, this was imatinib rechallenge was a strategy which was used when we did not have further treatment options. But now, since we do have multiple treatment options, usually we go on to them without imatinib rechallenge. That said, it must be said that approximately 10% of patients who are rechallenged with a higher dose of imatinib of 800 mg, they can have responses which are sustained. But since we have better options now, we would not consider that. A reminder about compliance, just like there is data in CML, there is data in GIST as well. Up to 25 to 35% of our patients are not compliant with GIST, and in smaller studies, this has gone up to 50%. So it includes simple reasons like forgetting to take the drug, as well as just patient choice because they feel they no longer require it. So on follow-ups, please ask your patients whether they are taking imatinib, and in case a patient has progressed quicker than you think, look for compliance issues. Even though imatinib works very well, 2 to 2.5 years of imatinib, you do develop resistance, and that could be generally secondary resistance is what we see, and these are because of acquired mutations, commonly in the exon 13 and exon 17, as I had mentioned earlier. These are the further line options in GIST: sunitinib, regorafenib, avapritinib, and ripretinib. The last two have been approved only over the last 1.5 years. I've also mentioned pazopanib because it is something that we often use, and there is some prospective data for the same. One thing you must realize is that the responses seen with imatinib are 2 to 2.5 years. None of these drugs cross 6 months. Majorly the progression-free survivals are 5 months or so. So the first line is the best treatment for GIST, but you do have other options. We now have a drug for the PDGFRA D842V mutation called avapritinib, and it has shown some remarkable responses in patients with this particular mutation. This is just a pictorial representation of, from 2002 to 2020, the number of drugs that we now have for, the treatment of GIST. So, as a summation, we should all understand that it is the c-KIT mutation and PDGFRA mutations which are the drivers in GIST. We should do mutational testing in almost all patients with GIST. In localized tumors, surgery is the backbone. We occasionally use neoadjuvant approaches. And in resected patients, in high-risk patients, we always consider imatinib for 3 years. In the intermediate risk, some guidelines say that it is not mandatory, but here we do consider. For advanced GIST, imatinib is the mainstay, and ensure compliance in your patients. Ask for compliance in your patients, and we now have multiple options, newer options in GIST for the management of these tumors. With that, thank you for your attention, and I'll be happy to take questions. So I'll start with the questions in the chat box. Sorry, just one minute. So Dr. Hasmukh's question is that an asymptomatic 2 centimeter nodule in the stomach, which is where we have the maximum data, we can observe it and with repeated endoscopies at 6 monthly intervals. More than that, at any other site or the stomach should be removed. The cell of origin is supposedly, okay, I missed this. It is the interstitial cell of Kajal, which is considered the cell of origin. And the morphological differences are tumors like a leiomyoma, other spindle cell tumors, though our histological pathological diagnosis banks on IHCs with the CKIT and DOG1. Do you wait for results on mutation testing? No. We start with imatinib 400 milligram and then call the patient after a month and then increase the dose based on the mutational reports. Dr. Lingraj's question is, did the AIO study look into the type of KIT mutation and benefit of imatinib? More for exon 9 group. What is our practice for exon 9 adjuvant TKI? So the theoretical discussion on the AIO was that the longer duration probably had more benefits in the exon 9 group, and that is why the results were positive. And later when they went and looked into this group, they found that some patients had received 800 later, and those patients benefited with the 800 milligram, which is why we now use 800 in the exon 9 mutants. Our practice for exon 9 adjuvant is 800 milligram. There is no randomized data for this, but there is biological sense. Hence, we use 800 milligram. In certain countries where insurance is a key, they have still not allowed that. So when do you perform the first scan after initiating neoadjuvant imatinib? So it has been seen that you can get metabolic responses with imatinib within 5 days of starting imatinib. But obviously we don't do scans at 5 days. We repeat a scan at 2 to 3 months. We are actually in the neoadjuvant setting, we try and get PET scans done because the metabolic response is quite gratifying. Then, sorry, what is this? So Dr. Vanita's question is, if exon 9 mutation is present, do you give imatinib 800? Yes, that is what we do. What about patients of what about the management of patients with high risk disease but with resistant mutations in the adjuvant setting? So in the adjuvant setting, the D842V we observe, and that is the recommendation as well. We do not consider imatinib. Thankfully, these are a far smaller number. The resistant mutations are actually very few in number. So other than the D842V and the rare younger age groups where you have SDH mutations and BRAF mutations. So in the SDH and BRAF mutation subgroup, that likely imatinib doesn't act as well, but it is not a resistant tumor. So we would still consider imatinib. There is some data that sunitinib might help, but this is very, very limited data. So other than the D842V, PDGFRA, we will consider imatinib even in the other tumors. So Dr. Lingraj's question is, are there any concerns for imatinib level achieved? So TDM has been evaluated in advanced GIST, but it has not been standardized like in CML, where there is far more work. And the absorption thing, I think there have been studies done, and there is no issue with that post a gastrectomy. Even more so because a majority of the patients with resected gist in the adjuvant trials were having a gastric tumor. So Dr. Kishore's question is, biopsy at progression in advanced gist, we try and do it, yes, predominantly to look at what is the type of um, secondary mutation, especially in those that were c-KIT 11 mutants. There is some data to suggest that if you have exon 13 mutation on progression, maybe sunitinib works better, while if it's an exon 17 mutation, maybe regorafenib is the better choice. So it helps to some extent if you biopsy at progression. Avapritinib is not used is not available in India. We actually tried to get it on compassionate basis during COVID. We were not able to procure it. Okay, what do you mean by switch inhibitor? Right. So I'll just try and show this from the diagram here. I okay, just 1 minute. So what you mean by the switch inhibitor is that normally drugs like imatinib and all that only occupy the ATP binding pocket of the c-KIT receptor. Now what the switch inhibitor does is it attacks this point as well as the onward pathway for action of kinases. It stabilizes that as well. So it has a dual mechanism of action. So that is why it is called a switch inhibitor. So not only does it act on the ATP binding pocket, it also acts on, the downward kinase aspect of the receptor, and prevents propagation via that signal pathway. That is the mechanism of action of avapritinib. I'm not able to show this here. Yeah, so that. Then for the first question, I meant how many of these asymptomatic patients will progress and at what time? Oh, okay. Dr. Hasmukh, I'm not aware of the timeline for those patients. I could get back to you on that. I'm not sure. Do we use NGS now for mutation testing in TMH? We usually don't, because what we do is that we sequentially test for c-KIT and PDGFRA because of the cost involved. I guess you could do the NGS, and we do it in patients where there is a confusion or a suggestion of a complex mutation. Then we do the NGS, but routinely we are not doing NGS for patients with GIST. Concept of oligoprogression, local therapy, and then continue same TKI like M1 in lung. There is data for local therapy. Let's say that the primary alone has increased, and the sites of metastasis like the liver, or vice versa. There are small data sets from Southeast Asia, especially Taiwan and Japan, where they have done this with reasonable results. So yes, there is some data for this, not prospectively, but small retrospective cohorts are there to suggest this, that you can consider the thought process of oligoprogression and treat with local therapy followed by continuation of TKI. So that's the questions on the chat box. Any questions from anyone else? Any of the residents who have any questions?
Anant, I was just typing, but can I ask?
Yeah, please, ma'am. Yeah.
So somebody who has a hereditary syndrome, say Carnes or neurofibromatosis, do you manage them differently, or is the adjuvant therapy different, or anything, or it's very similar? And do they have differential outcomes?
Yeah, they do lesser. I mean, in case you have let's say an NF1 or a Carnes, if they are low risk, they probably do better than their adult cohorts. But those that are high risk probably have more recurrences when treated with adjuvant imatinib. Does that make sense? I mean, does that answer your question, madam?
Yeah. So I guess then do you stop at 3 years though then, or do you go to 5?
Yeah. No. So uh, almost all the what I'm saying is based purely on very, very small cohort results. So there is no data to go beyond that. No, you would consider 3. And I mean, we see a fair number of GIS, and over the last 5 or 6 years, I can't remember the last kid under 15 or 18 that I saw with GIS. So it is that rare.
Yeah, Anand sir, Lingraj here.
Yeah.
So you have, as I asked my last question, oligoprogression. So you have a GIST which is metastatic, and you get a small new lesion in the liver, suppose, and the primary in the stomach is, say, well controlled. What do you do? Like, you do what kind of local therapy? Will you change? What is the how do you approach at our center?
Yeah. So the question, what we do in practice, for which there is some retrospective data, is assume it's a RFA-able lesion or something. My personal take would be to biopsy that and then consider LDT just to see what the biology is, whether there is a secondary mutation or not. And then if it is a single site which has been addressed, continue imatinib. This is what we do also. Does that answer the question?
Yeah. So my intention was that doing surgery versus RFA, or changing to TKI, which looking at the mutation and then change the TKI, changing to
There's no head-to-head. No.
There's no head-to-head.
No,
Okay.
no. I mean, unlike lung and stuff where you have much larger numbers, these are very, very rare tumors. So to get that kind of prospective data is very tough. But yes, the Southeast Asians routinely do this. They hit the site of growth and then continue the same TKI as well. Yeah.
Thank you.
Any other questions? I guess not. So I will be sending the PPT and some reading material, today or tomorrow, so that the residents can read more on advanced GIS. The whole idea was just to concentrate on the pathology, because I think second line, third line, everyone will write. But I will send you guys something to read. Thank you, and back to Kumar sir.
Thank you, Anant. Very nice lecture. I also learned a lot.